my name is Dr. Choo. I'm from Cardiac Vascular Sentral KL. Today, I hope to be able to share with you a new kind of treatment approach for our patients with severe aortic stenosis. And I hope at the end of the lecture, you will be able to understand there's a lot more that you can offer to our patients who otherwise would have been left without proper medical therapy. So let's start. Aortic stenosis really has been with us for many years. It is actually the most frequently seen acquired valvular heart disease in adults. If you look at the population, maybe about 1 in 20 people above the age of 65 may have aortic stenosis to various degrees. If they develop the severe form or severe degree of aortic stenosis, it confers very high short-term mortality after they begin to have the onset of symptoms. If you look at this slide, this is a CT scan of the aortic valve. You can see how the white parts of the valve are the calcified ones which are restricted in motion, and that's why the valves get so stuck. They cannot expand or cannot open, and that's why you get a severe aortic stenosis. If you look at the progression or the prognosis of patients with aortic stenosis, they are very asymptomatic for many years. But once symptoms develop, they can get angina or chest pain with exertion. At that point in time, their life expectancy may be about 5 years. When they develop syncope or fainting episodes, their life expectancy drops to about 2 to 3 years. And the worst of all is with the development of congestive cardiac failure, less than about 50% will live beyond 1 to 2 years. Now, if you look at the curve of the natural history of aortic stenosis, again, you realize how patients with aortic stenosis remain well for so many years. But once they develop symptoms, their curve or the trajectory just drops. They have very high risk of morbid events as well as mortality. Now, what do we have for patients with aortic stenosis? Traditionally, the only option for them would be to undergo a surgical aortic valve replacement. And this has been the standard for decades. But we must also remember that going through surgery is a major surgery, and you know that aortic stenosis, especially the degenerative form of aortic stenosis, often happen in the elderly. It does confer a high degree of morbidity as well as mortality, up to about 20%. But if we look at the reality in the world today, although we know that patients with aortic stenosis benefit from surgical valve replacement, many of these patients are denied surgery. It's all over the world, various series, up to half of patients with severe aortic stenosis actually did not get the required or necessary treatment. It happens even in today's modern world, like in the United States. Many patients, more than half, remain not treated. Now let's go back to how this new therapy for aortic stenosis comes about. Back in 1985, we know that there are many patients with aortic stenosis that are sick, but they are unable to be treated because of the comorbidities. One of the possible options that was available is actually to use a balloon to dilate the valve. That's the aortic balloon valvuloplasty. And that was the first case, if you look at the slide here, first in man procedure. And that gentleman, after having a balloon valvular dilatation, remained relatively well for up to 2 years. So that was really a memorable thing to us because it tells us the possibility of a non-surgical treatment for the severe aortic valve, but a severe aortic stenosis. But the only problem is the durability of valvuloplasty. Many of them actually have a recurrence of severe stenosis within a few months. Therefore, if you ever want to try something new, which is going to be compared with a gold standard, which is surgery, it can only be tried on a very sick patient, which is actually a no option for surgery. So that opportunity came in 2002 with a 57-year-old gentleman in France. He had multiple problems like previous lung cancer, he had chronic pancreatitis, he actually was admitted for subacute limb ischemia. He was treated. During that admission, he developed worsening heart failure. He had been turned down for surgery 3 times. So really, this man is not a surgical option. his LV function was actually very poor. And look at this. This is the gentleman or the physician who actually devised the first aortic valve stent. This was actually crimped, almost like you made it in your kitchen, a valve that is crimped on a 30mm balloon, and they performed the procedure through the groin, through the venous access, entered the right heart, punctured through the atrial septum, went down the LV, and then went retrogradely, went through the aortic valve before they placed a valve, which was placed just nice. And you could look at the picture, no regurgitation and well-positioned valve. So this man actually did very well. He actually remained well for many months, but he subsequently died of some other events. But it tells us the possibility of doing this procedure. Now let's look at the uptake of TAVR or transcatheter aortic valve replacement. Over the last 10 to 20 decades, it's just been picking up. The rates are just climbing all over the world. It is predicted that in another 10 to 15 years, the rates of TAVR is going to increase threefold globally. In some of the more advanced countries like the United States, TAVR is already higher in terms of the rates of transcatheter aortic valve replacement compared to surgical aortic valve replacement. Of course, because of the affordability of this new technology, at the moment, if you look at the geographic distribution, it's mainly seen at the advanced countries like Northern America and Europe countries. But I really suspect that in our part of the world, once this technology becomes more readily available, become more cost efficient, it will be used for many of our patients as well. Now let's look at the treatment of transcatheter aortic valve replacement. We have always been defining the patient's suitability for TAVR based on the surgical risk, because that's how they were actually treated initially. So there is a score that is used to define whether this patient is at higher, intermediate, or lower surgical risk. That's the STS score. Score below 4, STS is considered a low risk candidate. High risk will be 8 and above, so intermediate will be between 4 to 8%. There are two main TAVR valve designs that are approved. One is what's called a balloon expandable valve. The other one is a self-expandable valve. So if you want to sort of confirm the efficacy of this technology, it has to be tried first on patients that are at the highest risk. So the first trial to use TAVR was on patients who are surgical rejects, means inoperable patients. That's the partner trial 1B cohort. If you look at the statistics, it's very glaring. There is definite reduction of mortality, whether cardiovascular or all-cause mortality, when you perform a transcatheter aortic valve replacement against surgical aortic valve replacement. And they have data now, up to 5 years, that mortality benefit is actually maintained. The next group, of course, will be patients deemed to be high risk for surgery. So you might want to consider a non-surgical approach. So in this high surgical risk cohort, in the partner cohort A, you find that there is actually equivalent, at least similar mortality at the end of 1 year between TAVR as well as surgical aortic valve replacement. And that equivalent sort of rates of mortality was maintained up to 5 years follow-up. Again, telling us that inoperable and high-risk surgical patients do well with transcatheter aortic valve replacement. The other platform, which is the self-expandable, that's a core valve, similarly showed that they are as good. In fact, in the core valve high-risk trial, they had a mortality benefit of the transcatheter technique against surgical technique. So by follow-up to 5 years, the core valve mortality seems to come down, but at least they are as good as the surgical aortic valve replacement. So I think we are very clear up to here that for high-risk surgical patients, TAVR is definitely as good, if not at least in the short term better, than surgical aortic valve replacement. Now let's then look at the next category of patients at intermediate risk. Here in a summary of up to between 2 to 5 years, both valve platform, both the balloon and self-expandable, we have similar mortality rates. But you must also understand that over the last 10-15 years, this technology has just advanced so fast and so much. In some of the earlier trials with intermediate risk group, they were using the earlier version, for example here, the SAPIEN XT. As they moved on to a newer generation stent, which are better profile, better delivery with some other safety features, we also have development or improvement in the self-expandable valve platform, the core valve platform as well. And with that, you see that if you use the newer generation valve, you might even see a sort of mortality advantage over surgical valve replacement in the intermediate risk group. Beyond that, in this intermediate risk group, we also found that it's not just about mortality, there's also improvement in terms of less stroke in events, less stroke in the groups having the partner or the balloon expandable stent. Similarly, in the self-expandable platform, we also found in this intermediate group with the newer generation, there's also as good in terms of mortality rates, but also other improvement in the endpoint like reduced stroke events as well. So I think we've gone through for now, at least we're very clear that for severe aortic stenosis, for the inoperable group, high risk or intermediate group, TAVR is definitely a viable option. It is as good, if not better, than the surgical aortic valve replacement. So the guidelines have been trying to keep up with the development of the technology. Today, the patients with intermediate risk group is considered, at least for TAVR, is a class 2A. Of course, surgical is always class 1. The bigger question now will be, can you extend the benefit of transcatheter aortic valve replacement to the low risk groups of patients? We had some very interesting data that came out in early 2019 in the ACC meeting for both platforms, both balloon as well as the self-expandable platform. And basically what we have shown in this low risk TAVR group, that again we have similar or at least lower TAVR mortality rate at up to 2 years compared to the surgical aortic valve replacement. We always talk about mortality because that's most important, whether the patient dies or not. But there are other important endpoints as well. In these low risk groups, you will find that overall the stroke events are definitely lower when you perform transcatheter approach against an open heart surgery approach. With the new sort of developments and improvement in the TAVR platforms, we expect to see lesser and lesser stroke event rates, as you can see from this curve here. Another important endpoint is patients after procedure. We do not want to keep coming back for repeat hospitalization for heart failure and so on. And so again, very clear, even for the low risk groups of patients, if you perform TAVR, they have less chance of coming back to be readmitted to the hospital. We must not forget, it's not just about admission and so on. There are other important key issues like risk of kidney damage, new onset atrial fibrillation, and bleeding concerns. All these are also in favor of transcatheter aortic valve replacement. Clearly, you can also see that having a less invasive procedure, patients have better quality of life. They recover much faster from a transcatheter approach compared to an open heart approach. Depending on the cost modeling, in the long run, we also have some models to suggest that transcatheter approach may be more cost efficient compared to the surgical aortic valve replacement approach. Now we have seen that we have gone through the whole gamut of spectrum of patients from the highest risk to the lowest risk, and all these are very clear that TAVI is as good, if not better, for selected patients. Overall, you can have up to 12% less mortality up to 2 years with a transcatheter aortic valve replacement compared to a surgical aortic valve replacement. So is it time to change our thinking? 20 years ago, we were saying that surgery is the gold standard. If the patients cannot undergo surgery, we consider a transcatheter approach. In 2020, 2021, I think we might have to reverse the position. TAVI may perhaps be considered the gold standard, and only if they cannot undergo a TAVI, we will consider a surgical aortic valve replacement. Interesting, isn't it? So is it time to say bye-bye to surgical aortic valve replacement? Maybe yes, maybe no. Well, depends on how you look at the fact. You know, Trump has got a lot of alternative facts. I'm glad we don't have to deal with him very much longer. The COVID and all this stuff is just crazy, the things that he's just twisting the fact. So let's look at also the fact about TAVI, whether it's actually correct and how we should interpret it properly. The fact check should be, although we talked about earlier that we may extend the benefit of TAVI to low risk group, you must understand the trials a bit better because there are some groups that are not represented in the low risk trials. These include patients who have bicuspid aortic valve with severe annular calcification, and this has to be a transfemoral approach TAVI. So there are a number of things that we have to consider, because some patients are excluded from the low-risk trial. So we need to be more objective with the clinical trials. But clearly we must say that there are still some patients that may still require a surgical aortic valve replacement. We must also not forget, TAVR is not without its issues. At least immediate peri-procedural issue, there may be issues with perivalvular leak. There may be higher need for pacemaker implant after a TAVI procedure compared to a surgical aortic valve replacement. There's also still, although reduced risk of stroke with a TAVI as well. Of course, we have come up with ways to overcome this. There are some distal or brain protection devices to reduce the risk of stroke. In the longer term, we still are still not too sure about the durability of the TAVR. We know that TAVR is actually a biological valve, it's not a metallic valve. We have follow-up up to 6 to 7 years, which shows that it's as good as a surgical valve, but beyond 10 years, we don't really know. So this will be an issue, especially if you want to use it for younger patients. There may be also issues if patients need future sort of treatment to the coronary artery, because there may be difficulty in accessing the coronary artery through the stent valve frame. Now, if you look at the data that we have so far, because degenerative aortic stenosis usually is seen in older age group, patients who undergo TAVI, most of them are about the age of 80 and above. In those with a low risk, they are actually age about 70 plus. That is why we are not too sure about offering this therapy for patients in their 50s and 60s, because we're not sure if they need a second procedure. Of course, a repeat TAVR or valve-in-valve is still possible. Assuming that they have a durability of 10 years, we can give them another 10 years after the second TAVR procedure. So, ladies and gentlemen, I think we have gone through the whole spectrum of disease of patients that are deemed to be inoperable by surgery to the patients that are possibly operable but given now options of TAVR. The RCT evidence in summary clearly shows that we have not only lower mortality, there's possibly less stroke, less atrial fibrillation, better hemodynamics of the valve so far compared to some of the surgical valve. There's no scar again. If you look at the picture, having a small puncture in the groin and you leave the hospital with just a plaster against a big open chest wound, of course that's different in terms of the invasiveness as well as the recovery potential for the patient. Of course, patients have quicker recovery with percutaneous approach against surgery. Here, I know you all love Mick Jagger, isn't it? I love Mick Jagger. Everyone wants to move like Jagger. Look at this video. This is actually Mick Jagger himself posting on Twitter 6 weeks after his TAVR operation. He's dancing like a young man. So you can't imagine him doing that if he's undergone an open heart surgery, right? So that's one of the great advantages of percutaneous transcatheter aortic valve replacement. Of course, at the end of the day, the benefits of the procedure that we have looked at must be weighed against the unknown, like the durability of the valve, the need for repeat coronary procedures and so on. We have to look at the patient's expectation, and patients need to be informed before deciding what is best. So ladies and gentlemen, I hope we have seen how transcatheter aortic valve replacement has improved and evolved so much over the last 18-20 years, from a niche procedure for patients who cannot perform surgery to quite a standard therapy today. In fact, it may be said to be the preferred therapy for severe aortic stenosis in patients above the age of 75. So let's be aware that there's this option available for our patients with severe aortic stenosis. Otherwise, many of them would have been left without any treatment option, leaving them to the natural cause of the disease, which is actually very malignant. We've also, here before I end, I'd like to show you a real case that we had. It was actually a 92-year-old lady with multiple problems, ischemic heart disease, chronic kidney disease, had multiple admissions for heart failure and chronic kidney disease as well. So we performed a TAVR procedure for her in September, and that's the valve that you could see there. And just look at the difference before and after. On the right side is actually her heart before the procedure. See how weak the heart is, and after the procedure the heart has gone back to a normal function, and she's very well today. So I think as this technology continues to evolve and advance, I think we promise that maybe the outcomes may even be better. There's now broader indications to even patients at lower risk. We are still not too sure about some issues like durability, future care, but again, the whole decision making has to involve the patient and looking at the patient's expectations and as well as the cost factor. Thank you very much, and I hope you enjoyed this lecture, and we hope to be able to see some of our patients being given the best options possible. Thank you.